Dear guests, I would like to welcome everyone to our webinar. My name is Edmund Kiełbasa. I'm member of board Metrum Cryoflex and scientific director. Welcome doctors, welcome companies, welcome key account managers representing Metrum Cryoflex in more than 30 countries all over the world. I would like warmly introduce and welcome Dr. Agnes Stogicza, doctor from Medicine University in Szeged. I don't remember the name of the city. I'm sorry to that. Szeged in Hungary, in Department of Anesthesiology and Intensive Care, and co-owner and the main faculty in the Pain School International program. And for me personally, a great doctor, always supporting and creating innovation in pain fields. And due to that, our guest today will present a new approach and new usability of the new probe for the knee denervation. To understand what is the new in the new approaches, it will be most important part of today's meeting. First, however, I would like to show you some principles and some technical issues regarding this new shape of the cryoprobe in off-patient testing. Please, Monica, can you put the first movies? Okay, this is the standard cryoprobe, A13, 1.3 millimeters, quite popular for the many indications. It's typical probe usage for the cryoanalgesia or cryodenervations of the genicular nerves. Is the straight probe with the round shape of the ice ball creating. This is the exactly similar probe to the probes producing and delivering to the other systems like iovera, Myoscience, or Epimed, or Inomed, and the other companies. Just to remind and to see how it's difference between the standard probes and the standard approach and the new shape of the new cryoprobe. And let's go to the second movie. And this is, you see the probes working in the 37-degree ultrasound gel. That is the presentations looks like in the almost body cavities. On the right side, you see the same probe in the piece of meat. The probe is, as you see, the curved, bended, is rigid, 2 millimeter diameter and 2 millimeter freezing area, freezing tip. The golden part of the probe is the freezing tip. The rest part, silver one, is only the metal warm during the approaches and the freezing. Of course, both probes, the straight one and the curved one, are visible in the ultrasound, and is what is the more important and exciting, the lesions, the cryo lesions creating by that probe is completely visual under ultrasound guidance. What you will see during the live cases demonstrations, as well as during the presentations of Dr. Agnes Stogicza. Let me also introduce Monika Milewska from Metrum Cryoflex. She is responsible for the organizations of this meeting. Thank you, Monika, for the perfect organization.
My pleasure.
Thank you so much for the exciting numbers of the participants from all over the world. From the technical point of view, if you have any question, please chat during this meeting with Monika. She assists you. And Monika, please introduce few words regarding Q&A part.
So first of all, welcome everyone. It's a great pleasure to hosting you here. I would like to tell you that in the right corner, you've got the chat window. As you've already introduced yourself, please use this window chat to put all your questions, which will appear during the presentations of Dr. Agnes Stogicza. So after the presentation, after her part, we will have the Q&A session, and Dr. Agnes will be choosing the questions to answer. And then, of course, after the webinar, we will answer all the questions which will appear in the window. If you have any problems, please let me know.
Thank you, Monica. Dr. Stogicza, Agnes, I'm so excited your presentation. Stage is yours. Please, welcome.
Thank you so much for the introduction, and thanks for the opportunity. I will work on sharing my screen, and then we can go. So I want to welcome everybody. I think this is an exciting topic, partly because there's so many patients with knee problem, and it's a low-hanging fruit. We can reach it. It's a nice and safe procedure. It's a perfect area to get even started with pain management, and it's just a wonderful opportunity. Now, the one thing I am kind of experimenting now with you guys. So I made it as also not just a presentation, but also kind of a Q&A where you can, MCQ, where you can vote. So I would like everybody to connect to the QR code with their phones. That means that you will see the slides on your phone, but also you will be able to vote when it comes to voting. Okay? And then I think we can go. Maybe I show you the QR code a little more. I'm hoping everybody connected, and then we'll see about that QR code a little more. Next slide, not this. So about me, I am Hungarian. I trained in Hungary. I practiced in Hungary, and then I spent 8 years at University of Washington as faculty, or I did a fellowship first. Then I spent 2 years at UBC and St. Paul's Hospital, and in a private in Canada, and then I returned back to Hungary. I speak for a couple of companies, and I teach on a variety of courses. I still would like to do one thing to get the QR code visible for you guys. And then I will continue. Show instruction bar. Good. Show QR code. Okay. Maybe I'll show a few more times and then here. Okay. So I'm going to start with, and please everybody connect to the QR code. I don't have like a full contact with you guys, which is difficult a bit, but here we go. So I'm going to start with the conclusion, just in case if you get tired or bored or have other things to do, at least you heard the essence of this talk. So what we know for sure when it comes to knee denervation, and we know it from radio frequency studies, that the bigger lesion, the better outcome. We also know that the nerves are a bit everywhere, but we don't quite know where. We kind of know, but not always. And there's some variations that we need to be prepared for. So as a main conclusion, I would leave that message with you. Let's put a big enough lesion that compensates for both, for the variety of the nerves and the number of the nerves, and that may provide better outcomes. And this is really why we're talking about now this opportunity with this gigantic ice ball that this new probe can place. I have 6 main learning objectives: to understand the anatomical innervation of the knee joint, to compare fluoroscopy and ultrasound-guided techniques, to discuss advantages and disadvantages of various radiofrequency methods, look at the evidence, look at the size of the lesion, and see about this cryo method. And we will also play a live procedure after my talk, so you can actually see the procedure done on a live patient. Before I get to it, I want to invite everybody, or your fellows, or your residents, to the Pain School International course. In 2025-26, it's going to be 3 modules. A lot of it will be online. interactive workshops. This is partly why I'm trying now these interactive things with you, with live procedure demos and cadaver workshops on site. So please join us. Registration will open June 1st. Now here, oh, there we go. This is what I wanted. So I'd like you to vote first. How many people do we have? I want to see like 100 answers. Here, yes.
40 at the moment.
If you haven't connected yet, then please connect with the QR code. And I'll wait a little bit because then it gets like, as we go, we'll do more and more and more. Okay, so okay, numbers are coming up. I'm still waiting a bit. We have 62 answers so far. 64, it's coming up. So I'm still waiting.
And 238 participants.
Yeah, it would be nice to get, I'm hoping that people will stay with me. That's how I can check if you're with me or not, because I randomly will have questions.
Agi, we can bring back for this slide on the end of your topics, maybe. Also, then afterwards we can check.
And we will. I'm not waiting for that. I want to see the answer, and then it's kind of a warm up for other questions, so I see what to expect.
Right. Gotcha.
Numbers are still coming up, so. Okay, so to conclude, a lot of you are doing cryoablation, and some of you don't do the procedure at all, but this can change soon enough. Okay, wonderful. This gave an opportunity for everyone to connect, and you can see now that you have it on your phone as well. Okay. So what do we know about knee OA? That it's 80% of all the osteoarthritis burden worldwide. It's a really big problem. The global prevalence is over 20% in individuals aged 40. And if you could see that slide behind the book, you would see that the prevalence is really, really increasing with age. It's also increasing with weight. And you also see that knee arthroplasty is not the perfect answer. It's perfect in many cases, but we know that 20-30% of the patients are left with chronic knee pain. So radiofrequency or cryoablation, knee denervation may provide an answer. And this is actually a book on how to avoid an unhappy knee replacement. So let's talk about joint innervation. Can you vote now as well? Do you know when the first studies were published and identified? When were small nerves, the Superomedial Genicular Nerve, the Inferomedial, and all first published? Good. It's exciting. For me, it's exciting. I hope it's exciting for you as well to see these bars coming up and down. Okay, make your bets, and I'm going to continue. I'm going to just wait for 50 answers. That's fine. So, surprise, surprise. If you look at the next slide, so we see that 92 was a nice guess. And so, okay, so people are voting 1992. So look at this. This paper was published by Ernest Gardner in 1948. So it is really a long time ago that this been studied. And if you look at these actual nerves, Superomedial Genicular Nerve, nerve to vastus medialis, intermedius, and so on, you see that he actually really identified most of it. And if you look at this is a table summarizing how many other attempts there were to identify which are the nerves that are consistently there and found or not found. And this was a paper by Lee Dallon and Gregory Horner. They are plastic surgeons and did a lot of knee or joint denervations. They added some of the cutaneous nerves to the information. So this was the first report on knee denervation. So it's a lot of years later, in 2011. This was a radiofrequency denervation, fluoroscopy guided, and patients were followed for 3 months. And you can see on the right of the screen that radiofrequency group was much happier at 3 months. Now then the idea came, can we do this ultrasound guided? Can you answer this question for me? Which statement best reflects a key anatomical information in knee denervation? So first answer, genicular nerves are clearly mapped and consistent across patients. The nerves supplying the knee are limited to 3 main branches. Nerve locations vary, so larger lesions may compensate for variability. Only posterior nerves contribute to knee joint innervation. Okay. Oh, everybody knows. Okay, I'll come up with a more difficult question now. Fantastic. So nerve locations vary, so larger lesions may compensate for the variability. So this is the ultrasound study. You can see it's quite nice if we understand this image in the very middle. That's the adductor tubercle and the adductor attachment. And you can see just medial to the adductor attachment, you see the nerve dissected. So this would be one target for doing radio frequency denervation. And this is what you do when you look at it with ultrasound. You will identify the femoral condyle, the adductor attachment. You can see where the ultrasound probe is, and you will place your lesion just under the adductor attachment. And you can see these arrows are marking the adductor tendon. Now, if you go to the tibial part, here your main target is the medial collateral ligament, which is marked by the arrows. And under the MCL, you would find the junction of the shaft and the condyle. So it's kind of the same concept. Many recommend following the arteries. However, these arteries are very, very inconsistent in older populations. In arthritic knees, the arteries can be everywhere, not necessarily here. So here is the beautiful study that came later, 2018, by Philip Peng and John Tran and their group. And what I just want you to see that on this is it's beautiful dissections. And they looked at nerve frequency. They dissected, I believe, 10 cadavers. So this is the anterior knee, and they also worked on the posterior knee. But if I want to simplify, because I like simple things, then this is their key image. One color is the nerve frequency of the frequency of one nerve. So the green nerves, which are nerves to vastus intermedius, could be everywhere where you see green. And if you want to simplify this a bit more, then what we say is, well, we kind of don't know where the nerves are. I'm just going to start my timer because I forgot that. We don't know where these nerves are, but we can safely say that they are sitting all around the capsule, right? It's just like hip peri-peng block with pericapsular nerve group block. You can think of this the same way of the knee. It's a pericapsular situation going on here. And I'm not even going to tire anyone with the names yet here. And this study looked at how steady are these nerves. And you can see that some, the Superomedial Genicular Nerve, the inferior patellar saphenous nerve, the superolateral, the lateral, the inferolateral genicular nerve are pretty steadily found with bony landmarks. So there's lots of debate going on. Where do we put the lesions? Because the outcomes were not always that perfect. And if you do denervation, either radio frequency or cryo, you see that it's pretty good, but there are surprises when it's not so good. So the debate is going on. Shall we do all these 6 lesions? Do the superomedial, inferomedial, and superolateral genicular nerve, plus the nerve to the vastus medialis, vastus lateralis, and intermedius. So shall we put lesions everywhere? It's a lot of lesions, right? It's a lot of work and a lot of time. So I don't have a slide on it, unfortunately, but there is a debate to place the. I don't have the paper. I have the slide here, but I don't have the paper I wanted to show, but I will in a month. The debate is, shall we place the lesion exactly where the initial needle was placed, initial study showed, which is a bit anterior, or shall we place it more posteriorly and more distally? So that's the debate. But if you wanna simplify, we think of the Peng study. There are branches coming from anterior that are anterior, and there are other branches coming from posterior that sit posterior. So if you place your needle anterior, you miss the posterior branches. If you place your needle posterior, you miss the anterior branches. That's the situation with the medial knee. And then you go to the lateral knee, and turns out it is the same. If you go anterior, you miss the posterior. If you go posterior, you miss the anterior. And similarly, at the Inferomedial Genicular Nerve, it's a nice long nerve that if you make a bigger lesion, you will get a higher likelihood of getting it. So how can we solve this problem? I think we should try to get more nerves. And it's often a question, are we not going to cause a problem? No, because there are so many nerves, there's no way we can fully denervate the knee. As the more we get, the better, the closer we are to reaching our goal, which is pain relief. So there's a study that compared monopolar lesion versus bipolar. It's radio frequency, right? If you see in the right bottom, bipolar with 2 needles, which makes a bigger lesion simply. And they had a good amount, 25 patients in each group. And this is what they got, that the bipolar is better. If I want to again simplify, bigger lesion, better outcome. I'm just going to skip this now. So what happened with cooled radio frequency? There's a lot of misunderstandings, so I'm just quickly going to touch on it. Cooled radio frequency has nothing to do with cryoablation, other than it's a denervation form, but it's not cold. It's a hot lesion, but because there is cooling at the tip of the needle, it creates a larger energy zone, a larger area gets burned. So it creates a nice big lesion. So here is the CocoGen trial that compared conventional, which is a smaller lesion, with cooled RF, a bigger lesion. And what did they find? Again, that the patients with the cooled RF, bigger lesion, they were better. So the lesson here learned again, bigger lesion, better outcome. Now here is this study that came out in the Regional Anesthesia and Pain Medicine, very prestigious, 2022, and they compared a bipolar lesion with sham. And what did they find? They found a good number of patients, 32 in each group, and what you can see that the sham is not any worse than the bipolar lesion. So that's quite disappointing. But then you look into the article and you find that they did one thing very interesting. And if you treat patients, you know this. So the first steroid injection always works like magic. It's true for the knee, it's true for the shoulder, it's true for the low back. The first steroid is amazing. But then as you treat the patient on and on, the second and third and fourth steroid have shorter and shorter and shorter benefits and don't help. So in real life, the patients who really need this procedure are the ones who are already exhausted the steroid. So what did these guys do in this study? They excluded patients who had steroid, right? So the ones that really need the procedure were excluded. And in the sham group, they actually gave steroid. They gave steroid in both groups. But that means that the sham arm was an active treatment arm, and they selected out the patients who are particularly likely to benefit from a steroid. So you cannot expect a bipolar lesion to beat a brand new patient with steroid injection. So I think this study has some flaws. So what can we do to make a larger lesion, since I think can agree that the bigger lesion is better? So this is the probe that Edmund showed at the beginning. It makes a pretty gigantic lesion. You can see I'm dripping saline on the needle. It's a 2 millimeter wide needle with 2 centimeter active tip, and the whole yellow is active. So that's going to make a nice ice. I will ask for the slide from Edmund to use it next time. And what's the technique? You will see the live procedure, so I'm just going to quickly review the technique. So first, you can look at the left image. You identify the target zone by identifying the junction of the shaft and femoral condyle and adductor tubercle, and you place the probe out of plane, just like it showed. This is the angle on the bone. And then you rotate your probe, so you see on the right side of the screen, you rotate your probe and you visualize the bone, and you visualize this nicely bent cryoprobe as it slides on the periosteum. Okay? You really want to stay with the periosteum because that's where the nerves sit. And this is what you see once you have the lesion going. You can confirm it in many ways. This is the ice ball in out of plane view. And here, because there is no video running, now I learned you cannot see, but there's a pretty big lesion. You will see it on the live procedure demo. So what's the deal with the posterior knee capsule? One thing is, I would say 90% of the knee pain is medial, or maybe 95. And 90% of the 90% is medial posterior. So the posterior knee capsule probably can be left alone, except for some cases. But you have a chance to do a block that's like an IPAC block, but you need to be aware that there's a bunch of exciting structures: sciatic nerve, tibial, femoral nerve, the artery, and the vein that needs to be considered and avoided, but it's possible to do an IPAC cryo. What complications have been published with radiofrequency? Nothing too much. You can have a hemarthrosis, a periarticular hematoma, of course, infection, and you can damage the skin, but these are things that you can avoid for the most part. So what does the evidence say? Let's do a quick review on evidence. So this is a systematic review, a meta-analysis of randomized controlled trials. It included 15 RCTs with over 1,000 patients. They looked at VAS, WOMAC, and global perceived effect. And what they found at 6-month follow-up is that RF is an efficacious and safe treatment for relieving knee pain and improving knee function in patients with knee OA. This is another paper, looked at 9 trials, RCTs and control trials. Unfortunately, the targets that were treated are a bit heterogeneous, but it's again 600 patients, and it proved that 3 to 12 month patients benefit. And this is a paper that's really fresh. It came out yesterday. This is a retrospective review by Giuliano Loblanco and the team. Reviewed 90 patients, looked at VAS, WOMAC, neuropathy, and quality of life score. And the finding is, if you look, first box on the left is pain. You can see that at 12 months, there is good improvement and sustained in pain. Of course, it's always worse after the 6 months. Pain is a bit picking up, but it's still much better than baseline. It's the same for function, that's the WOMAC score, same for neuropathy. It's much better in 3 and 6 months, and then it slowly picks up. This is the DN4 DNIC study or outcome measure. And then the quality of life is also much improved. And then over time, it fades. But that's when you can do a redo, no harm, same targets. This paper has looked at infrapatellar saphenous for knee OA, and what it found that 121 patients, 59 of the sham, followed for 6 months, and statistically significantly decreased knee pain compared to sham up to 150 days, which is a half a year. And this one is percutaneous freezing for prior to knee arthroplasty. And again, the targets were anterior femoral cutaneous nerve, infrapatellar saphenous, 50 patients in each arm, less hospital stay, less opioid use. Again, good news. So here I have a couple of questions. I see how active you are. If you're active, I'll keep it. If not, then I'll skip it. So according to the 2022 systematic review cited in the presentation, what was the overall conclusion regarding RF treatment for knee OA? Option 1 is RF less effective than intra-articular steroids. RF showed no improvement in pain or function. Safe, effective treatment, increased or RF increased opioid post-procedure. Oh, everybody knows. Very good. So we can agree that we can help patients. That's a perfect agreement, I think. Okay, so what do we do? Post-knee replacement? This is a very small study, but also it's a problem patient group, right? Because they already have the knee replacement, and surprise, surprise, they're not doing so well. So this was a small study with 19 patients, but achieved significant improvement in VAS and function, and there was no surgical revision needed, which is, again, very important. Once the revision comes, the patients are not doing so well. Some more questions before the end. Which nerve branches were identified as consistently innervating the anterior knee joint capsule in anatomical studies? I think there's also quite an agreement. So these nerves, yes, all of these nerves listed there were really identified to be readily there. What is one key limitation of targeting the genicular nerves too anteriorly during the innervation? Okay, so yes, it's pretty obvious. If we go to anterior, we miss the posterior branches, which are the superomedial genicular nerve. Which technique detail is essential for effective cryoablation during knee denervation? So how can we maximize the benefit? And I think this is very important. Absolutely. So everybody is following that concept that if you go a bit kind of not touching the periosteum, your lesion size or your lesion position will not be where you want it to be. Okay, we can skip this. I will skip this. I'd like you to do this one maybe. So there was this paper that we discussed, which is a 22 sham control study. Yes, so this is exactly, you cannot call steroid a sham in a steroid naive population. Wonderful. Warms my heart. This is something we discussed. Okay, so as a conclusion, most pain of the knee is medial. So the most important targets are medial, which is why I always start medially. If you go too anterior, you miss the posterior branches. If you go too posterior, that's the other way around. Bigger lesions, better outcome. And here we go. We have this big cryo lesion that we can make, and it may provide better outcomes. We do not have any studies to prove that it's better, but conceptually, it really makes sense. And then hopefully studies will come out and show if it's inferior or superior to the previously available methods. Thank you so much for your attention. I think this is it for now. I wish I had one more slide. Maybe I'll make it so you can vote if putting those questions in actually makes sense. So I might make it very quickly and then you can vote. I'll give the screen back to Metrum. I think they will play a live procedure now. Edmund, you're muted.
Thank you, Agnes, for the presentations. It's so exciting. It's time for the live demo cases. Monica, if you are ready, you can start. It's not this one. It's from the live demo.
Tell me exactly which one it is.
If you're not ready, guys.
Monica, can we start?
Yeah, but which one you have to tell me?
Sorry? No, don't play the teaser. Play the full thing. And while you find that, I will ask this question from the audience real quick because I made it. I would like you guys the same QR code. I would like to answer. Hopefully, I would get like 60 answers because it would modify the way I do this in the future.
Monica?
Okay, I like that. At least 40 people are awake. That's good. That's good. Awakened. Okay, so when you are ready, Monica, I will stop waiting for this. I can step out in a moment. I was just curious to see. Okay. Monica? I have, shall I play? I don't know, Edmund, I have the live procedure demo. If you guys can't find it, I can play it. Is that better?
Yeah, I think so, because I've got those too.
You have more.
This one and this one.
It's not
So
this one.
No. This is a teaser, but we have a full movie on how to do this procedure.
Yes.
Okay, while you're looking, I think actually I have it. Wait a sec. I don't know if it's the final version. This is 1 minute. Yes, I think I have it. Okay, I can play it. I don't know if there is sound coming, but if not, that's why I thought maybe it would be today, but I can do. If there is no sound, then somebody need to tell me, then I'll just comment. Is there sound? Hello, I am Dr. Stogicza, and today we're... Guys, is there sound going or not?
It's going on. It works.
Okay, then I will not have to comment. That's why. To demonstrate knee cryoablation with a newly developed cryoprobe that has a special 2-centimeter active tip to provide a strip lesion. So here you can see the cryoprobe. It's a curved cryoprobe that has 2-centimeter active tip. And the concept is to place it along the femoral shaft and condyle junction to create a nice long strip lesion. The placement will be initially out of plane because that is how you can identify your target area. So we're going to find the femoral shaft and we'll slide distal until we find the junction between the shaft and the condyle, which is marked with blue dots here. Once we have this, we're going to place the probe, of course, after local anesthesia, out of plane to touch bone. And then, just to make sure we're really nicely placing it along the bony surface, we'll turn the probe to have an in-plane view, and we're going to slide the probe nicely to touch the bone. And with that, the superomedial nerve would be done And then we repeat an identical procedure for the inferomedial. Again, touch down on bone out of plane, rotate the probe, and slide in plane to make sure a nice big lesion is placed along the shaft and the condyle junction. And then we will repeat an identical procedure again, identifying the junction of the shaft and the condyle, placing the probe out of plane on bone, rotating the ultrasound probe, and then sliding along the bony surface. This is a 70-year-old female who has arthrosis of both knees, and she tried and failed conservative treatment, medications, and physical therapy. And she's not interested in surgery, but she's also BMI 38, so maybe it is good to avoid surgery. Previously, we did cryoablation on the left knee and also regenerative medicine, and essentially the left knee is problem-free, pain-free, which is better outcome than expected. This treatment is also combined with regenerative medicine, and the concept is to provide short-term good relief with cryoablation and then a longer-lasting relief with regenerative medicine. In her case, it was PRP treatment. Let's review the equipment. So here I'm prepared for a sterile prep and drape. One goes under the patient's leg, one will go on top of the leg. Here is local anesthetic, lidocaine 1%, 10 ml, that should be enough. Here is the cryoprobe, and you can see that this part, the 2-centimeter active tip. And of course, I have a sterile probe cover as well and sterile gel. We are going to start with the inferomedial genicular nerve. So this is towards the feet, and that towards the head of the patient. Before we're starting the procedure, of course, we're going to test the cryoprobe to make sure that it's freezing. We're going to look. It actually freezes the humidity from the air, but you can also test it with a little bit of lidocaine and see if it's forming an ice ball. And you can see it really does. We're going to identify our first target, the inferomedial genicular nerve. So left is cephalad on the screen. This is the tibia. And by sliding cephalad, I'm identifying the junction of the shaft and the condyle. And I ran out of gel. So here you see there's a bit of a start of a mountain or that's the junction of the shaft and the condyle. And if I scan more cephalad, you can see the meniscus. So I'm going to center on the junction of the shaft and the condyle. You can also see the MCL very nicely, the medial collateral ligament. And I'm going to enter with my hypodermic needle to provide local anesthesia at a nice big distance now, 1 to 2 centimeters away from my probe. And I'm aiming to numb up the center of the screen, which is where I expect the genicular nerves to be. Also make a little bit of a skin wheel. And a tiny bit of skin nick so the probe can go through. And it's a bit trickier to manipulate a probe because of the pretty rigid cable. So I might have to reposition a bit. Maybe like this is better. So back on target. And I'm gonna go through the skin, touch down on bone, and you can see I'm touching bone. You can see the movement of the tissue. And I'm going to rotate my probe. And you can see where it's touching. It's touching the tibia. Okay. Now I have a curved needle, and my plan is to lay that curve along the tibial shaft. And it's pretty tricky to lead this, so I'm going to actually go with 2 hands and rotate and advance. And rotate and advance. And let's see the way it looks. You can see the tip. I can advance a tiny bit more to get to the posterior aspect. Again, with full control, 2 hands. And this looks good. Maybe a notch more. Again, if you can't proceed, you turn the probe upwards and then immediately come back and hug the bone. Okay, so here we are in a perfect position, and I'm going to start the first freeze. You can see, hopefully in a moment, that there's an ice ball or a strip lesion is shaping at the tip of the needle.
1 minute, 15 seconds.
So the hypoechoic is the ice, the hypoechoic structure. Let's turn on color on the ultrasound.
1 minute left.
What you see is always, you see some level of movement. Turn off color. Okay, we didn't see the movement with the color, but you can see the ice ball as I'm following the cryoprobe.
30 seconds left.
Here it starts, and I'm tracking it posteriorly. Let's look at it in another view. Again, now you can see essentially 2 big ice balls are covering the periosteum nicely. This lesion is going to go for 90 seconds twice.
Defrosting.
This is the defrosting time, 30 seconds, and then another lesion will follow. So here you can see a nice big ice ball covering the tip of the cryoprobe. Here is tibia, ice, tibia, ice, tibia. And once the ice melted, we can remove the probe and move to the next target. I can test if the cryoprobe is still engaged, and it is, so I'm not pulling it out yet. Okay, and then we can move to the next target, which is going to be the superomedial genicular nerve. Let's identify the target. I'm going to put my probe somewhere where there is definitely femoral shaft, and I'm going to slide distal until I can identify the femoral condyle, and there it is. Mind you that the patient's leg is externally rotated, so that's why it looks like I'm scanning anteriorly, but I'm not. So here is my target. I'm going to start with the local anesthetic. If you look at the depth, we are at 4 centimeters depth with the target. So I'm going to keep a fairly big distance to be able to nicely lay my probe along the shaft. And you can see that there is intra-articular fluid, so that might alter my program. Okay, so here we go. I slipped laterally from, and now we can go. You can hear me. See how much distance I'm keeping from the
I
ultrasound
can see the
probe?
tissue moving.
That is to allow eventually placing the probe parallel to the bone. So if you go closer to the probe, then it's not going to work.
I'm going to check one more time for intra-articular, for the suprapatellar recess, if it's in my trajectory. I'm trying to squish the fluid. Okay. So here we go. Let's do a little bit of a skin nick. And then I'm going to advance the cryoprobe. Feed it through the skin with lots of control. It's surprisingly harder than placing a local needle. Okay, you can see it, but you can see it, of course, less because we're at the 4 centimeter depth, but you can still see the probe touching down on bone. And now I'm gonna feed it anteriorly, or sorry, posteriorly. Now I'm gonna put some more local anesthetic because the patient doesn't like this so much. Let's go again through the skin. Touching down on bone. It's pretty much going straight down to make sure we don't miss the femur. And I'm gonna check my location, and that seems to be correct if you look at the tissue movement. And now I'm gonna slide my needle anteriorly to create a strip lesion. Okay. Okay. Here we go. And I'm constantly keeping in touch with us. And this is my first position for freezing. Freeze, please.
Freezing.
Here you can see the needle position is still touching the femur. And if we look at it in a short axis here, you can see the
15
probe.
seconds left.
I'm tracking it, and it does indeed arrive to the junction of the shaft and the condyle. So once we're done with the 2 freeze cycles here at the Superomedial Genicular Nerve, I'm going to remove the probe and go on to the Superolateral Genicular Nerve. In order to save time, I'm going to now put local anesthetic to the lateral aspect of the
15
thigh.
seconds left.
For the Superolateral Genicular Nerve, we're going to do the same thing again. Identify femoral shaft. There you go, bright white line. Slide distal until you can identify the junction of the shaft and the condyle, which is pretty obvious in this position. I'm going to center on my target. Local anesthetic again. Go ahead. And here we go again with the cryoprobe. Feeding through all the way to the femur. I'm going to confirm that I'm at the appropriate location at the junction of the shaft and the condyle. So it is at the junction of the shaft and the condyle. So I'm going to look again in plane and slide posteriorly. You can use the rotation of the probe or the curve of the probe and see how far I got. I can see I can advance a little bit more, maybe a couple of centimeters. And check again. It's pretty much a two-hand job to advance it with control, especially in a bigger thigh. I'm happy with this position, and I'm going to start freezing.
Freezing.
This gives me another chance to identify if my target is good, and it is exactly where I want it to be. Junction of the shaft and the end
15 seconds left.
condyle. You can see the ice ball and the probe as well. And again, we're going to do 2 90-second lesions, and with that, the procedure will be complete. So again, here we are doing 2 lesions, 90 seconds twice with 30-second refrost in between. And this gives us time to review possible complications. Of course, infection and bleeding must be mentioned, although if the procedure is done right, there is no major blood vessel here. One needs to remember the saphenous nerve on the medial aspect of the knee. And of course, if we're placing the needle way, way, way too posterior, the tibial and the peroneal must be remembered. With this, the procedure is complete. Once the defrost is done, then you can remove the cryoprobe. The patient can expect post-procedure pain for 2 or 3 days, but most often they already can tell the improvement once they step off the OR table, because they can just move better.
Okay. Okay. Okay, so hold on, where are we? I'll stop screen. I will have one more question if I have time to type it up at the end. But let's review the questions that came to me, and that maybe, again, I found them. How many milliliter of local anesthetics are you using per cryo? Super question. It allows me to touch on the diagnostic block. At the diagnostic block, I use half and half at one side. So a total of at most 1 milliliter for my diagnostic block, which means total of 3 sites, 3 milliliters of lidocaine. Okay. If the patient doesn't have, it's not even a diagnostic block, it's more like a prognostic block. Is the procedure going to work? So diagnostic or procedure, prognostic block, 1 ml at each side, and I distribute it at the length of where I expect to freeze. How much local anesthetic do I use when I do cryo? Maybe 5-6 ml. But in an average patient, you can use comfortably even 8 to 10 ml per site, right? A total of 300 milligrams of lidocaine, 1% is safe to use. But it's typically not necessary. Maybe in a bigger patient, you would need so much. But like the patient that I showed you, a BMI 38, that's a difficult one. Probably I would use more. So
Question, do I believe that it's possible to do cryo on the posterior capsule? Absolutely. I wouldn't try on a patient on 38 BMI, but on a smaller patient where you can clearly visualize and understand the tibial and peroneal nerve, you are doing like an IPAC block, right? So you want to visualize the posterior surface of the femur. You want to understand the nerve situation, the artery, and the vein, and you don't want to compromise them at all. If you don't see them, I wouldn't do it, but you can safely hide behind them. Is the knee probe a single-use probe? Yes, it is a single-use probe, unfortunately, but I'm lobbying to make it multi-use. What's the name of this cryo probe? I don't think it has a name. It's a knee probe.
We will send to all participants all technical data together with the reference number for this probe afterwards.
With so much lidocaine in deep, how do you stimulate to locate the nerve? I tell you, I do not stimulate. I place it based on the anatomical location, and the lesion is typically big enough. It would be very difficult because of the size of the probe. If you don't provide some sort of anesthesia, it would be difficult to dig it all the way in without really hurting the patient. Can we do both knees at the time? And do I recommend ultrasound and fluoro hybrid technique at the same time? My answer is always yes. Whenever you have an opportunity to do hybrid, always do, because it gives you a bit more information. You learn from it. No matter how many you've done, if you combine the two, there's always a lesson to learn. But it's doable really nicely, even on the ultrasound-guided, as you could see on this rather high BMI patient. And yes, I do both knees at the same time. It's mostly tiring for me. It's not tiring for the patient. They can just relax and chill. You can have amazing conversations with them during the procedure. Any reasons for using nitrous instead of CO2? No, it's what you have. It's just compressed gas. And this is something that Edmund and Metrum can guide you through. Any compressed gas works because it works based on the Joule-Thomson effect. As it expands at the tip of the needle, it will cool it down. So, doesn't matter. What is the price of the probe and how many lesions can be done with one probe? You do as many lesions as you want, and price, Edmund will tell you, or your local distributor tells you. Do you drain the liquid from the recess? Oh, great question. So this is also something that I can share my experience. Yes, I do. If someone has so much fluid in the suprapatellar recess, you actually go through the joint capsule. I drain the fluid first, and of course, you work very sterile, like you saw in the movie. If I do motor test before I cryo, no, I don't. Maybe I would recommend for someone who starts doing this procedure, but realistically, if you understand the anatomy, the shape of the femur, the big motor nerves are actually really far away. You're not compromising tibial and peroneal nerve are way posterior. So unless you get really lost, there is no risk of hurting them. If I would do motor for radio frequency, I have to fess up. If you hear an answer from Andrea Trescott, she would say she always does motor and sensory. I'm not as diligent. I think I'm on an efficient side. I don't do motor, not for radio frequency. So wet knees were answered. Why don't I use fluoroscopy? Oh, because I think this is superior. This is easy. Why do I use ultrasound and not fluoroscopy? Not because of any legal issues, as the question asks, because ultrasound is easy to use. You can really make sure that you are laying across along the periosteum, which you cannot make sure with fluoroscopy. With fluoroscopy, you will have an AP, a lateral view, but you will not see for sure if your ice ball is laid along the bone. Never see, if I've seen skin injury with less fat, never seen skin injury. The only way you can cause a skin injury if the active tip actually kind of sticks out of the patient. But because it's 2 centimeter active tip, you can hide that in the patient. So no skin lesion. With other procedures, you may be concerned about skin lesions for supraorbital or supratrochlear, smaller targets, very superficial targets. Then you can use your warm finger, or you can use saline dripping on the skin, and that protects it.
Agnes, we missed the one question upwards. There is a lot of fluid around the knee.
I missed it because I kind of answered it before. If there is fluid in the suprapatellar recess, you drain it.
Okay.
Yeah. Do we still need a diagnostic injection? You always need a diagnostic injection. It tells even if the procedure doesn't work, it tells yourself and the patient that you try to be as meticulous in predicting if it's going to work or not. So you want to know, right? You want to predict if it's going to work. How many days of cryotherapy works in the patients? How long the cryo lasts? Long time. I am a bit difficult. I have a difficulty answering it because I typically combine cryo with regenerative treatment, thinking that cryo works short term, regenerative treatment work long term, and then typically I actually don't even have to repeat it.
Like a cocktail.
It's an amazing cocktail because you want the quick relief because the patient then will know that you know what you do, and then the PRP or stem cells will kick in, and then it's all happy. Do you do cryo at Dr. Canal? No, I don't. And the reason is if you get the saphenous nerve, it really has a lot of innervation to the vastus medialis, and you will get a vastus medialis atrophy. How many knees total you have done up to date? That's an amazing question. Maybe Edmund can answer how many probes I got with this technique and probably hundreds before this technique. Edmund, we can think of the answer. I would say
it's over 70.
Oh, 70, see? Because we work hard. So a lot. And we do collect data, so hopefully we will come out with something eventually. On the presentation, No. The question is, on the presentation, the inferomedial was addressed distal to the MCL attachment? No, it was under the MCL attachment, proximal, closer to the joint line. Which regenerative? Where intra-articular? I use both BMC and I use stem cell. I actually use fat-derived stem cells. That's the new hype at the clinic. For half a year, we've been doing the fat-derived stem. I do intra-articular. I use the biomechanical unit approach, like surrounding important ligaments, and intraosseal when necessary. If I do PRP and cryo simultaneously, I try not to, but yes, I do. It works perfect together. Really, it does. It's just a lot of work, but it does. I do it together sometimes. Okay, I think we ran out of the questions.
Thank you so much. Thank you so much, Agnes. Thank you so much for all those questions. I have just one more question. Maybe I missed during the procedures. And how deep you are going with the lignocaine injections before placing the cryo? You are going
all the way. I make a skin wheel, so a skin wheel, and then all the way to where I expect my cryoprobe will go.
Okay, you are touching the needle to the periosteum or not?
I'm touching the needle to the periosteum, and even with the local needle, I'm sliding to cover my target. It allows me for procedure planning very nicely.
Okay, well. Have you get any post-procedure pain determined by the periosteum?
It is 2-3 days, maybe painful, but it's a different pain. It's a post-procedure pain. I don't mind it so much because the knee pain is decreased. I did. Right? I have some more questions. If I do infrapatellar saphenous branch, yes, I really do. If it's nicely visible, let's put it this way. If I have a perfect relief, perfect answer with what I showed you, I don't. If it doesn't work, if there is a reason for infrapatellar saphenous injury, previous arthroscopies or falls or swelling of the infrapatellar saphenous, then I certainly do. And this is an area that's very nice. You place the probe onto the nerve and it stimulates, the patient really confirms that yes, this is the area, and then you freeze. Cryos, yeah. How much time? Yeah, I think I answered this. You can do PRP and cryo together perfectly.
Yeah.
Okay.
Okay.
Thank
you so much.
Sorry, there is one more question. How does the temperature used in cryoanalgesia affect the recovery of the treated nerve?
I can't give you any evidence to that or any data, and I have never analyzed. But what we know from basic science, if you're using temperatures under 100, and here you're using minus 70 degrees, it's a second degree nerve damage, right? So the nerve regrows in theory in 6 months to a year, but I suspect with the bigger lesion, it must take longer for the full regrowth.
So the last question is there any damage to surrounding vessels like thrombosis, etc.?
I have never had any trouble experience. But again, if you look at from a safety perspective, Edmund said I've done 70 of this and hundreds of the previous. It's not a big data, not big enough data, right? But I had so far lucky, no complication.
But I can tell you from the intracostal nerve, we are doing the intracostal approaches for the percutaneous and the thoracoscopic approaches. And during the thoracoscopic, in the vascular bundles is almost laid down on the nerves. And it's more than 1,000 procedures did with our approaches. We never get any data coming from the thrombosis of the even distractions of the vasculars.
Yeah.
No more questions.
Okay.
No more questions. Thank you very much. It was lovely.
Thank you so much. Thank
See
you so much.
It was amazing. Take care.
Thank you so
Bye-bye.
much.
Thank you so much.
Thank you so much for the participants. Next week, our marketing department will prepare the summarize of these our meetings, and we will send you some more materials. That please be patient. And I would like warmly welcome for the next week, for the next Friday, for the next webinar with the president of the Chest Wall International Group, Dr. Manuel Lopez from Cleveland Clinic, from Cleveland. He will introduce the cryoanalgesia for the intracostal nerve during the chest wall deformities operation. Thank you so much. I wish you a nice weekend. And once again, thank you, Dr. Agnes Stogicza.
Thank you so
Thank you,
much.
everybody, for participating. Have a lovely weekend. Bye-bye.
Bye-bye.